العيني.
شرفينا يا فندم. السلام عليكم ورحمه الله وبركاته. استاذ دكتور ايمن فؤاد، استاذ دكتور مازن نجا، دكتور جمال بيه، دكتور علي بيه، دكتوره منى امين، اهلا وسهلا بحضراتكم جميعا وكل عام وحضراتكم بخير. ان شاء الله احنا يعني هتبقى ان ريزومي هنتكلم النهارده على updated focus on GERD management. My agenda بنتكلم introduction, case study, definition of GERD, pathophysiology of GERD و clinical manifestations, diagnostic evaluation و treatment, and concern على البانتوبرازول in GERD. GERD is a common, counting for more than 5.6 million physicians visit each year. Around 20% of adults in Middle East countries. Prevalence of GERD is increasing about 4% per year in parallel with increasing in obesity rates. Majority of patients with GERD don't seek medical attention. This iceberg, what's seen by gastroenterologists is is a peak, but many of GERD symptoms don't seek medical attention. Our case presentation, this male 58 years old smoker with bad dietary habits. He has intermittent chest pain with external burning that radiates to his mid-back. He describes this pain as a stabbing. Our patient says that the symptoms occur after he has eaten a large meal in the middle of the night, which often awaking him from sleep. He awakens with shortness of breath, coughing, and bitter taste in his mouth. In the recent days, he started to have nausea that's often worse in the morning and when he skips a meal. He complains also, he describes heartburn up to 4 times daily. His workups, CBC is normal hemoglobin and normal CBC. Normal renal function, ESR is normal, but he had high CRP, H. pylori angine is negative. More investigations, which is a very important investigation, had patient is free from any coronary arteries insufficiency as had done normal stress ECG. What is the definition of GERD? My definition is a condition which cultivates when the reflux of stomach contents causes troublesome symptoms or complications. Esophageal GERD syndromes are classified as those that are symptom-based and those that are defined by tissue damage. So, there are 4 main physiologic mechanisms protect against esophageal injury: the clearance mechanism, mucosal integrity, lower esophageal sphincter competence, and gastric emptying. سريعا الباثophysiology of GERD, primary barrier to gastroesophageal reflux is a lower esophageal sphincter. It normally works in conjunction with the diaphragm, but if this barrier is disrupted, the acid goes away from the stomach to the esophagus. This patient has a heartburn and substernal burning regurgitation. So, as a heartburn, when the patient says that heartburn is a classic symptom of GERD. And he said also it's postprandial, aggravated by changing position, and if took antacids, there's prompt relief. Back to basics, what are about guidelines? American College of Gastroenterology to نحاول نفض الخناقة هو GERD ولا مش GERD، هو cardiac مش cardiac. Patients with classic GERD symptoms of heartburn or regurgitation, which have no alarming symptoms, please, 8-week trial of empiric PPI once daily before meal is recommended. Attempting to discontinue PPI in patients who classic GERD symptoms responding to an 8-week empiric trial of PPI is recommended. So after the 8 weeks, please try to discontinue the PPI. We recommend diagnostic endoscopy as by the guidelines, ideally after PPI are stopped for 2 to 4 weeks, in which classic GERD symptoms don't respond during the 8-week or return again when PPIs are discontinued. We recommend endoscopy as a first line, our first test for evaluation of patient presenting with dysphagia or other alarming symptoms, such as GI bleeding, weight loss, dysphagia, or patients with multiple risk factors for Barrett esophagus, and this is a strong recommendation. This algorithm, patient heartburn with regurgitation without alarming symptoms, taking 8-week once before PPI trial. If there is complete relief, GERD likely, please discontinue PPI. But if symptoms recur, please endoscopy, upper endoscopy is recommended of PPI 2 to 4 weeks. The upper endoscopy can be Los Angeles classification B or C or D or Barrett, it's a GERD confirmed. But what about there is normal endoscopy or Los Angeles grade A? So there is here role of reflux monitoring of therapy, and consider other causing of symptoms. For patients with GERD who don't have eosinophilic esophagitis or Barrett esophagus, or whose symptoms, erosive esophagitis, have resolved with PPI, attempt to discontinue PPI. For patients with GERD who require maintenance therapy with PPI, the PPI should be administered in the lowest dose that effectively controls GERD symptoms. Maintenance PPI, مين ياخد PPI indefinitely, are recommended for patients with Los Angeles A, classification C or D esophagitis, and this moderate recommendation and strong level of evidence. Back to our patient, there is classic symptoms of heartburn and regurgitation. There is no alarming symptoms, so the diagnosis of GERD can be made clinically and the treatment can be initiated. And be sure, please, there are no alarming symptoms. What are alarming symptoms? That is dysphagia, early satiety, GI bleeding, odynophagia, vomiting, weight loss, or iron deficiency anemia. 2 weeks after treatment of this, our patient, there is slow improvement of symptoms. So there is now role of diagnostic test. ما تكتفيش بالعلاج. هنا ممكن يبقى uncertain diagnosis. ممكن في atypical symptoms. أو this patient زي our patient inadequate response to therapy. أو symptoms associated with complications or recurrent symptoms. Or if you decide to do anti-reflux surgery, so before it, we can should perform diagnostic tests. What are diagnostic tests for GERD other than endoscopy? Barium swallow, but not for GERD now. Don't use endoscopy as we mentioned, esophageal biopsy, esophageal manometry, pre-operative evaluation for surgery, and not recommended for GERD diagnosis alone. But you can rule out scleroderma like esophagus or ruling out achalasia. What about the most important, one of the most important investigations for GERD, ambulatory reflux monitoring? We can pre-operatively or for non-erosive disease or refractory GERD symptoms or GERD diagnosing questions, correlating symptoms with reflux, documental abnormal acid exposure or reflux frequency. Ambulatory 24-hour pH monitoring, very high sensitivity and specificity for diagnosing the GERD. There is wireless catheter-free esophageal pH monitoring. والمانومتري بيبقى assessing lower esophageal sphincter pressure and location and relaxation. And you can assess the placement of a 24-hour pH catheter and assessing peristalsis. We can, is very important, is that high resolution manometry prior to anti-reflux surgery. What are about upper gastrointestinal endoscopy? As we said before, is very important indications for alarming symptoms, therapy failure, preoperative evaluation, detection of Barrett's esophagus. Although upper endoscopy is frequently performed to help to diagnose GERD, is not the most effective diagnostic study because esophagitis is present only in 50% of patients with GERD. Back to the Los Angeles criteria, there is Los Angeles, as we see, A, there is one or several erosions limited to the mucosal folds and no larger than 5 millimeter. Los Angeles B says several erosions larger than 5 millimeter, but still limited to the mucosal folds. But C, the extending less than 75% of esophageal circumference, but extending over the mucosal fold. Los Angeles D, as we see, extending more than 75% of the circumference and erosion extending over the mucosal folds. برضو we can assess مهم قوي في الابر اندوسكوبي انواع الانكومبتنت كارديا من جريد A لغايه B هيل كلاسيفيكيشن. الهيل دي بتبقى ساعات بيبقى وايد باتيولس ومعاها سمول سلايدنج هيرنيا. طيب يبقى احنا لو قلنا مع بعض ديزيز الكوريزم يبقى انا اديت عيان جاي لي alarming symptoms equal upper endoscopy. It has no alarming symptoms. Please start PPI therapy 8 weeks. There is response taper to the lowest dose. No, please go to the upper endoscopy. Here we should suggesting extra esophageal symptoms. There is established esophageal symptoms as we say as sinusitis, as dental erosions, laryngitis. All of these you should consider referral to ear, nose, throat, pulmonary services. But after pH monitoring, there is abnormal, please optimize medical therapy and consider surgical and endoscopic therapies. Our case did upper endoscopy and relieved reflux esophagitis type A. What about treatment؟ انا هركز برضو على الفارماكولوجيكال تريتمنت واللايف ستايل. هو الجولينج اوف تريتمنت ايه؟ اول حاجه eliminating symptoms. تاني حاجه healing esophageal mucosa. Maintaining a remission for a long time and manage to prevent complications. What about the non-pharmacological management? Reduction of body weight is very important. Avoiding large meals, acidic foods, citrus, tomato, alcohol, caffeine. كان دكتور شريف مجاور استاذنا، هو موجود ولا مش؟ كان بيقول لي حاجه على الجيرد، وطبعا هي موجوده في الجايد لاينز، لكن ما فيش عيان ليه صفه واضحه للاكل الممنوع. كل عيان جيرد عارف الاكل اللي بيمنعه. يعني حتى لو جايد لاينز قايله سيترس توماتو، لكن بنكتشف ان في عيان عنده حاجه معينه، جزا الله عنا كل خير يعني. Decreasing الفات انتيك طبعا، و avoid lying down within 2 to 3 hours after a meal, elevating head of bed. كل دي حاجات نون فارماكولوجيكال مهمه جدا لتقليل تاثير او النون فارماكولوجيكال مانجمنت. طبعا الهيلث سليبنج بوزيشن ممكن نديكلاين، ممكن نرفع شويه البيت 15 ل 20 ديجري. نتكلم سريعا على الفارماكولوجيكال تريتمنت. نبتدي بالانتاسيدز، ده الاو تي سي اسيد سبريسنت. هي مشكله في الانتاسيدز والاتش 2 بلوكرز في التاكيفيلاكسس، ما اقدرش امشيه عليه فترات طويله، والى حد ما اقدرش ممكن اقلل الاعراض، ولكن مش تريتنج او هيلينج اسوفاجيال ميكوزا، ومش انديكيتد في حالات الايروسيف اسوفاجايتس. لازم ارفع البي اتش بتاعت الايه الستومك. الفارماكولوجيكال تريتمنت كان فيه سايمتيدين وفاموتيدين ورانيتيدين، اتكلمنا عليهم زمان قبل كده، لكن دلوقتي هو الكورنر سكورن اوف جيرد فارماكولوجيكال ثيرابي هو البروتون بامب انهبيتورز. هو الفاستر هيلينج، ويتفادى موضوع التاكيفيلاكسس، او ببساطه العيان مهما هيمشي عليه مش التاثير هيقل زي الاتش 2 بلوكرز. البانتوبرازول اور موليكيول النهارده البيرلوك، one of the most effective PPIs. طب احنا ليه اخترنا البانتوبرازول؟ مهم قوي قوي في الافيكاسي، ومهم جدا في السايد افكتس او الانتراكشنز. يعني الاورال ادمنسترد بانتوبرازول 40 مللي جرام 30 minutes before breakfast effective choice in managing GERD بيachieve high healing rates و successful relief of symptoms. طب هنا البانتوبرازول، طب ما في ديكسلانسوبرازول او اوميبرازول برضه individualized، في تلاقي عيان ارتاح عن ده، ولكن اللي مكتوب في البانتوبرازول versus other PPIs كان في ترايل راندمايز كنترول ترايل، لما قارنا بالبانتوبرازول اوميبرازول، هو الاثنين مع بعض يقدروا افكتيف في الكومبليت ريميشن والميكوزال هيلينج ريت، والاثنين هاي. ولكن الاكستندد بيريود، يعني العين بعد ال8 اسابيع لقوا ان العين يمشي على مينتنس او يبتدي سيمتوم ريليف، لقوا ان البانتوبرازول افضل من اوميبرازول في حاجه زي كده. والحاجه الاهم واللي كلنا عارفينها الدراج انتر اكشن، ان البانتوبرازول الى حد ما على قد ما نقدر في دراجز كتيره جدا جدا في مينيمال دراج انتر اكشنز. يعني تقريبا الكلوبيدوجرال والورفرين عندنا عيانين اسكيميك هارت او عيانين عاملين انتي كواجيوليشن، بنضطر ان احنا نمشيهم على لونج ستاندنج بي بي ايز كمينتنس. فالبانتوبرازول او بيرلوك الى حد كبير الى حد ما اقل انتر اكشن. وانا اسف طولت على حضراتكم وشكرا جزيلا.